Hi everybody, I'd like to welcome you all to the IFOMPT webinar lecture series. The title of our session today is The Role of Musculoskeletal Physiotherapy in the Management of Post-Concussion Symptoms, which will be presented by Dr. Julia Treleaven. My name is Pierre Rocha. I'm an executive committee member of IFOMPT, and I will be the moderator today. IFOMPT represents manipulative physical therapists around the world and attempts to set up educational and clinical standards that are driven by the available scientific and clinical evidence. We hope that the webinar that you are about to hear will assist you with providing some valuable information from a renowned and well-respected speaker. This webinar is a pre-recorded session. As such, if you have any questions, then please ask you to email us at either admin@ifompt.org or to email the presenter herself. We are very lucky and privileged to have Dr. Julia Treleaven present today's session. Julia is a lecturer and researcher at the University of Queensland. She has been researching whiplash and neck pain since 2000, and in 2004 completed her PhD, focusing on the neck's influence on sensorimotor control. She has continued her research in this area, and I was also looking at the role of the neck in dysfunction with those with headaches, dizziness, and post-concussion due to concomitant whiplash type injuries. She has over 100 publications in this area and written several book chapters, and is the author of the recent book, Management of Neck Disorders and an Evidence-Based Approach. Julia works part-time as a physiotherapist in private practice, managing patients such as those with whiplash, cervicogenic dizziness, and post-concussion syndrome. And she's been involved as a clinician on several whiplash randomized controlled trials. Julia is also an assessor at the Whiplash Physical Diagnostic Clinic, and she's been an invited speaker at many national and international conferences and workshops in the area of neck pain, whiplash, concussion, and dizziness. I would now like to hand over to Dr. Julia Treleaven to begin her presentation. Thank you very much. The floor is yours.
Thank you very much, Pierre, and I appreciate that nice introduction. And I would like to thank IFOMPT for inviting me to today. So we're going to be talking about the role of the musculoskeletal physiotherapist in concussion. We're going to look at the role of the cervical spine in concussion, the symptoms and signs of people with post-concussion symptoms or prolonged post-concussion symptoms, assessing the role of the cervical spine. How do we work out what role this has in those symptoms? And then we'll talk about the integrated management as well, and touch on some secondary and primary prevention with respect to the neck. So when we think about the potential damage that could occur with the head and neck, any head and neck trauma, you can see that in terms of the cervical spine, it doesn't take a lot of trauma, a lot of force, for example, to cause any cervical damage. So about 4.5 G-force is thought to be enough to sustain a cervical injury, whereas the forces are a lot larger for it to incur a concussion or a head injury. And so that's in the realm of around 60 to 160 Gs. So potentially when somebody's had a concussion, there's a lot of areas that could potentially be damaged. So the neck being one of them. You've also got ocular, brain, and peripheral vestibular, central vestibular, as well as damage to the autonomic nervous system, which has been termed as a physiological causes of some of the symptoms. But certainly when you've had concussion, certainly the forces are going to be enough to have caused a neck injury. So we need to consider that as an important component. The problem with concussions, so most people will recover, but about 10 to 30% of people will develop persistent concussion symptoms. Other people will have no complaints, but we also know that there's a risk of another concussion, so about twice the risk of having another concussion or another musculoskeletal injury, typically a lower limb injury. And we need to consider why is that, and perhaps there are ongoing deficits, and where might these ongoing deficits be in the absence of complaints. So the proposed mechanisms of these persistent symptoms are that physiological or changes to the autonomic nervous system, but certainly vestibular or cervical, and then visual certainly comes into that realm as well. So it's important that we can understand these symptoms and that we've got a better assessment of recovery so that we can return to people to sport better and perhaps for primary and secondary prevention of problems. So when we think about the neck, the potential symptoms that can occur post-concussion, you can see there that there's several symptoms that we do see in people with neck pain that certainly overlap vestibular and the concussion type symptoms. So it's very difficult sometimes to be able to determine where these symptoms are coming from, and we need to be able to do a really good assessment. We also know that people with neck pain have altered sensorimotor control, and this covers things like reports of dizziness and visual disturbances. So at least 50% of patients with neck pain will report visual disturbances, up to 70% dizziness in someone who's had a whiplash injury with chronic symptoms. We know that they have changes in their proprioception, in their balance control, and also impaired coordination of their eye, head, and trunk head coordination. We also know that people with neck disorders have problems with their ocular motor function, particularly with the smooth pursuit neck torsion test, which we'll talk about later on, with gaze stability, also things like near point convergence and changes to the cervico-ocular reflex can occur in people who have neck disorders, and that can be people without trauma as well. We also know that there is some evidence of neck impairments in people with concussion, so it's quite common, and we're also seeing that it can persist, quite a long time after the normal expected recovery time of about 2 weeks to a month, and it has been known to increase recovery time if people are complaining of neck pain. We also know there's some evidence of neck dysfunction in people post-concussion, so things like joint dysfunction, changes to their muscle endurance, and changes to their cervical kinematics, such as range, velocity, and accuracy. The other thing is that we know that treatment can help. Treatment directed to the neck can help with these symptoms. And so in Catherine Schneider's randomized controlled trial, she added cervical management to a vestibular program, and she was able to improve symptoms and also return these people to sport much faster when she added that cervical component. And then recently in this work that I've been doing with the US Army, we found that if we found people who had a cervical proprioception problem causing their dizziness, that treatment directed towards that improve their dizziness at a much faster rate than if they just had vestibular therapy. So we need to be able to try and work out what is the role of the cervical spine in post-concussion, with potential for it to cause headache, potential for it to cause dizziness, visual disturbances, sensorimotor control deficits. So we need an integrated approach though, because there's several other areas that could be involved. So it could be the vestibular system, peripheral or central. It could be that physiological or autonomic nervous system. It could be visual, and it could also be coming from the neck. So we need to have a good patient interview. We need to be able to assess the impairments in the neck and other be able to screen for the other systems. We need to be able to determine, is there interactions between the systems that are involved, and how much is the cervical spine contributing to that, and also for some differential diagnosis as well. So when we're thinking about differential diagnosis from our musculoskeletal point of view, obviously we need to be considering things like red flags, so things like cervical arterial dissection, if there's cranial nerve involvement, etc. We need to be thinking of potential non-musculoskeletal things that could be causing these symptoms, such as vestibular, ocular motor, etc. Is it a migraine or tension type headache rather than a cervicogenic headache? And then we need to identify, do we think the neck is causing the headache or other symptoms of sensorimotor control disturbance, such as dizziness or tinnitus or these visual disturbances. So we have some symptom screening that we should look for. And with neck pain, with the role of the neck, we need to consider the neck pain, dizziness, headache, visual disturbances, and fatigue as potential causes coming from the neck. Sometimes the nature and the description of those symptoms can help us. For example, with dizziness, you would be expecting more an unsteadiness or a general lightheadedness rather than true vertigo. Sometimes the duration can help as well, so the symptoms, how long they last for, that sort of thing. What things make these symptoms aggravated? Is it related to neck type things, or is it more related to visual things? And what's happening at the same time. But we know that just knowing about the symptoms and the nature and duration, etc., doesn't necessarily help us differentially diagnose. And we certainly need some tests that can help us with that. And the other thing to remember is that just because someone's complaining of neck pain doesn't necessarily mean they have a neck problem. And we know that people with vestibular pathology often report neck pain and stiffness, and also people with migraine and tension type headache often report neck pain, but may be more related to the headache itself rather than it coming from the neck. There are some outcome measures that we can use. So there's measures like the Rivermead, the post-concussion symptom scale, which ask about a series of symptoms that could potentially be occurring post-concussion. There's also a new tool called the Clinical Profile Screen, again, which runs through the gamut of symptoms that might occur post-concussion. That might lead you to then want to do some more impairment-specific screening tools, such as the Neck Disability Index for the neck, or perhaps the Dizziness Handicap Inventory, if you felt the problems were more related to dizziness and sensorimotor control. If there's more problems relating to sleep, then there's sleep questionnaires, etc. There's also some other questionnaires that you might consider. So things like the headache, you've got the HIT, where that can be helpful to identifying people who are having moderate to severe headaches. The brain injury visual symptom scale can be quite good, and it's thought that if you're scoring above 31 on that scale, that perhaps it's time to think about referring people on to someone like a behavioural-optometrist. And then for the autonomic nervous system, perhaps something like the Compass 31, which has been shown to be elevated in people post-concussion, as well as in people with migraine. So in terms of our cervical musculoskeletal examination, certainly we would be doing all of the things we normally do when we're assessing the cervical spine, thinking about range of motion, not only that, but also velocity and accuracy of their motion. We've got the Toby Hall's work on the flexion rotation test, which has been shown to be quite sensitive and specific to picking up C1-2 cervicogenic headache. We certainly would want to be doing a good manual examination, particularly of that upper cervical spine, because that's where the joints could be contributing mostly to causing headache, but also the high receptors in the upper cervical region for sensorimotor control. So the upper cervical spine will be really important. And then we've got looking at the neuromotor control and posture of the neck and the scapula as well, and then also looking at cervical and scapular muscle strength, which could be affected due to the trauma that they've sustained. In terms of the cervical sensorimotor examination, then we may want to use positional testing for vertebral artery insufficiency as a differential diagnosis for dizziness, and then we would want to consider sensorimotor tests specific to the cervical. Some are specific to the cervical spine, and we'll go through those now and see what that looks like. So in terms of joint position error, so this is where you're asking the patient to relocate their head back to the neutral position. So the patient's in neutral position, the target's placed, they close their eyes, and then they're asked to turn their head as far as they can comfortably go, and relocate back to that straight ahead position. And so you can measure the difference between their starting position and the position that they land. You reposition the head back to the centre in between repetitions. But certainly, if you're using this target here, the laser is 90 centimetres away from the target, and so the degrees have been calculated accordingly. And if the person's falling outside of the yellow line, then that would be an indication that they're abnormal. And if they're falling, way outside of that, then you can measure that and then convert it back to degrees. So that's a way of measuring position sense. You can also look at cervical movement sense or accuracy. So in this way, a clinical way to measure this. So this is somebody who's a normal person performing the task. So you're asking them to trace along that bold line as accurately as they can, and you're looking to see how many times are they coming outside of that sort of grey zone. So a normal would be around about less than 10 errors in about 25 seconds. And then this is somebody with neck pain on the right-hand side that you can see. You can see they're much slower. They're certainly deviating outside of the main area much more often than the healthy control person. And so that's a way that you can look at their cervical movement sense or accuracy with fine movement control. We can also look at trunk head coordination. So this is where you're asking the patient to keep their head still while they rotate the trunk on that head that's kept still. And we know that people with neck pain quite often have difficulty being able to dissociate that, and what they tend to do is they move their head in the direction that the trunk is moving. And we feel that this might be a problem with the cervicogenic reflex, which is a reflex that's designed to keep our head stable while we're moving our trunk on the body. Similarly, eye-head coordination we can look at, and similar thing, we find that people with neck pain have difficulty moving their eyes and their head independently of one another. So we're getting a patient to move their eyes independently first, then bringing their head to that point, then bringing their eyes back to the centre, and then head back to the centre. And we're looking to see whether they're able to dissociate head and eye movements. We also can look at gaze stability, and we do this with the cervical spine, looking at slow, fuller ranges of motion compared to the vestibular system, which we'll look at in a moment. And so what we're asking the patient to do is focus on the straight ahead on a target, and then move their head as far as they can comfortably go, keeping their eyes focused on that straight ahead position. And they can go into rotation left and right, and flexion and extension. What you tend to see with people with neck pain is that they are not able to keep their eyes focused. It may cause some symptoms, or that they're not able to move in a smooth way or in a much less range than they have. So that would be an indication that that's abnormal. Then we've got the smooth pursuit neck torsion test, and this test is thought to be specific for looking at the neck's influence on eye movement control. So what we do is we're getting the patient to follow a moving target of about 20 degrees per second, and then we compare what their performance is like when they're in that neutral position compared to a torsion position. So you can see I've kept the head still, and then we've rotated the trunk on that still head. And we see whether the eye follow ability changes. So if it gets worse in the torsion position, that's an indication that the neck is influencing their eye movement control. And what we're looking for is that nice smooth movement of the eyes backwards and forwards. We're not seeing any quick catch-up saccades, and then we compare. The biggest thing is the comparison between neutral and torsion. If they're not very good in neutral and they're the same amount of not very good in torsion, then that's not suggesting that the neck is involved. So we'll have a look at what this might look like in someone who has got a problem. So this is a lady who had a whiplash injury, and this is her in neutral. And you can see that she's following quite reasonably well with her eyes, moving backwards and forwards across the screen, and really keeping up with the target. Now this is her in torsion, and what you can see is every time she crosses that right side, she gets a quick catch up as the right. So just there, she gets that quick catch up. So not too bad that way, and then that quick catch up at the end as she's coming across to the right-hand side. So that's an indication that the neck is potentially affecting her eye movement control, because it wasn't there when she was in neutral, but it was certainly there when she was in torsion, where we haven't changed any afferent input from the vestibular system or other systems, but we've certainly changed the afferent input from the neck. So we've also looked at this effect of neck torsion on some of these other measures as well. So you can modify the joint position sense test by looking at a modified version with neck torsion. So with this one, we've got the laser on the trunk, and we're keeping the head still and asking the patient to relocate the trunk back on that stable head. So that's a way that you can really take out any afferent input from the vestibular system and isolate it to the cervical spine. We've also done that with tests of near-point convergence, where we've looked at the difference in their near-point convergence in a neutral straight ahead position compared to when we've put them into this torsion position. And we've also done that for balance as well. So we've looked at somebody in neutral, eyes closed, comfortable stance, and then we've kept the head still and turned the trunk and measured their balance as well. So that's another way that you can potentially look at those things. There's another test that we can look at. So looking at a sustained torsion test or a head neck differentiation test, and we can look at different components to help us to look at that. So in this one here, we're looking at the sustained torsion component, and we've got the patient with the eyes closed, and we're asking about any symptoms reproduced during those tests. Then we can compare it to if we do a sustained en bloc component. So in the en bloc component, we would be stimulating the vestibular system, but not the cervical system. And then we can also look at head neck differentiation. So this is faster movement. So this is trying to keep the vestibular system still, and then comparing it to when we're keeping the neck still and we're stimulating the vestibular system. What we found with normal people is that sometimes normal people will get symptoms with both the en bloc and the sustained and the torsion tests, and so probably that's an indication that they're having trouble integrating any kind of changes in that sensorimotor control system. But what should happen is if it's a cervical component, you would tend to see that they get symptoms more with the torsion test and not so much symptoms with the en bloc, and vice versa for the vestibular. So vestibular system, they would get more symptoms with the en bloc test and less symptoms when you're keeping that head still and not moving the vestibular system. For balance, it would depend on your patient and what they're complaining of, but certainly you can look at different stances of their feet position, looking at eyes open versus eyes closed. In neck pain, often it's more noticeable with the eyes closed, and we're looking at their ability to maintain the position for 30 seconds. Things like increased sway, particularly in the AP direction, is often a little bit more indicated of cervical. Sometimes, though, they might go into more rigidity to try and hold the position. And do they get any symptoms while they're doing that, those tests? We can also look at functional and dynamic balance. When we're thinking about whether the neck's involved, you can look at the time 10-metre walk with and without head turns or head up and down, and the quality of their walking while they're doing that. So with the neck, we try and make the movements of the head quite large and slow, so that they're really getting that good full stimulation of the cervical spine. And then you can compare their performance to when they're doing fast, small head motions, which is more related to the vestibular system. So that can be a way of trying to tease out whether you think it's more related perhaps to the cervical or perhaps more related to a vestibular problem. So that would be this, the neck type things that you would be looking for, but we need as musculoskeletal physiotherapists to have tools that we can screen out for some of these other potential problems that might be occurring. So one of a good test is a vestibular ocular motor screening tool. This has been shown to have good reliability for determining somebody with concussion versus a healthy control. It consists of a series of vestibular and ocular tests, and essentially asking people about symptoms at baseline, so the symptoms of headache, dizziness, nausea, and fogginess, getting them to rate those symptoms at baseline, and then you perform each of the tests and ask them to rate each of those symptoms again. And an increased score of 2 or more is an indication that that is potentially a problem that would need to be perhaps require further assessment or can be part of your management as well. So this is what that looks like. So smooth pursuit, similar to what we did with the smooth pursuit neck torsion test. We're performing it in that horizontal, but also in the vertical direction. Okay, so again, you're looking at the performance, but it is a lot of it's based on symptoms, because a lot of people with post-concussion symptoms can perform the test, but they have a lot of difficulty doing it, and so that then reproduces some symptoms such as headache and dizziness, etc. This is your saccadic eye movement, so you're getting them to move quickly from one point to another as fast as they can. You're looking to see that they're getting nice smooth movement, keeping the head still, and that and then asking about any symptoms after you've done the horizontal and then after you've done the vertical tests as well. This is the visual motion sensitivity. So with this one, the patient is moving through that full range, trying to focus on their extended thumb, and you're seeing whether that visual motion, they're sensitive to that and whether that increases any symptoms. You can also look at, so part of the that screening is the near point convergence and VOR, but another test, the optokinetic test, has been found also to be a good discriminator for concussion, along with near point convergence of more than 6 centimetres, as well as the VOR. So the optokinetic test, you're getting them to follow some moving stripes, trying to actually evoke an optokinetic nystagmus response. So again, you're looking to see, does that response occur, but also does it cause any symptoms for your patient. With this one, this is looking at near point convergence, so they have a target of a cross that they're bringing towards them, and you're asking them to tell you as soon as that turns into a single image to 2 distinct images. So it's not if it's blurry, it's 2 distinct images. So normal is around about less than 6 centimetres, but you can see this fellow here who actually reported no symptoms had near point convergence of around about 20 centimetres. So, and that persisted, you know, way after he was having any particular symptoms. This one is looking at the vestibular ocular reflex, so gaze stability. You can use a metronome to get them to perform it in a set speed, so that in the VOMs they use about 180 beats per minute, but in McDevitt they used about 220. So they're trying to focus on that straight ahead point, and they're moving their head as fast as they can in time with that metronome, and then you're seeing whether that reproduces any symptoms and asking them about, you know, headache, fogginess, etc., and looking for that increase in symptoms of 2 or more. So that's a good way of screening for vestibular ocular deficits, and certainly if there's other things you might want to, we'll talk about where you might want to refer on for a further vestibular assessment later on. In terms of further balance screening, so there is the BESS, which is used in the SCAT5. It's used on the field, looking at things like, standing on one leg, eyes open, eyes closed, etc. But it's consistently been shown to have no deficits in that subacute period. So after that initial 7 days, quite often people present with no problems with the BESS. But what we are seeing is that people are having problems with dual tasking quite often in a long time post their injury. And so a way of looking at that is you can look at the tandem walk test. You can get them just performing that test as fast as they can, and then you ask them to again perform it, but doing a cognitive task. So that might be doing subtraction, mental subtraction from a random number of, -7. So you might get them to say, I want you to count backwards in 7s from 91. And then they do the test and perform that cognitive task at the same time. And then you're timing them to see what does that, adding that cognitive task, how much slower does that get them. And certainly that dual task cost seems to be something that can be a persistent problem in people with post-concussion. And the final thing that you would want to screen for is people who have the physiological issue or autonomic nervous system dysfunction that relates to when they're having cognitive load. It can also affect them when they're trying to exercise. So they get an exercise intolerance. So essentially this test has been developed by Barry Weiler and John Leddy and colleagues at the University of Buffalo. So if you're interested, there's lots of work on this. But essentially it's a graded test where you're trying to gradually increase their heart rate, and you're measuring symptoms, you're measuring level of exertion, and also you're measuring heart rate, so that you can then determine their exercise tolerance, and then you can advise on the management of that with exercise, which we'll talk about later. So in terms of this test, it's a graded test. You're getting them to walk for a minute, then you're increasing the incline of the treadmill every minute. And at every minute, you're asking them about their perceived rating of exertion. And then you're also asking them to rate their overall condition. So you're looking for, so you would stop the test as soon as they reach that level of exertion of more than 17, if they're getting to the point of exhaustion or fatigue. If any of their symptoms increase more than 3 out of 10, then that would be an indication to stop the test. If you're really noticing that they're really impaired, they might be saying, I don't have any symptoms, but you can clearly see that they're having obvious problems and any obvious distress. That would be an indication of stopping the test. And then you would look to see at what heart rate was that when you had to stop the test, and then that's the heart rate that you would want to work sub-maximally for any treatment for that. So after you've done your assessment, then you would be trying to make some overall clinical reasoning decisions as to the role of the cervical spine in this person's symptoms, perhaps if there's any drivers for any neck problem. So for example, if you've got a visual problem, then that can certainly impact on the cervical spine by positioning, also by the effect on the muscles in this, particularly in that suboccipital region. So visual problems could cause a cervicogenic headache. But if you are not addressing the visual system, then that's going to keep generating and keep driving that problem. And then there might be interrelationships between the vestibular system and the cervical system, for example, or cervical and visual. So in everybody, it's going to be different. There might be some patients where you feel the cervical spine is a big component of their problem, but they have other factors. In others, you may feel that their visual or physiological or autonomic nervous system is one of the main drivers, with a little bit of components from the others. So it's important that you're able to make a decision as to how much you feel that that's affected. In terms of when you might consider referring on to a behavioural optometrist, so behavioural optometrists tend to look at not just sight, but also ambient vision, so things like depth perception, visual fields. Can you recognise, something in your visual field? Can you react to it quickly? Those sorts of things. So, as I said before, the brain injury visual symptom survey can be useful. If it's scoring more than 31, it's suggested that perhaps that's time to refer on to a behavioural optometrist. So it asks lots of questions about light and glare sensitivity, double vision, trouble concentrating when reading, depth perception, etc. That might be an indication that's needed. If they've got very abnormal near-point convergence, that also might be an indication, as well as if they've got abnormal or symptoms with smooth pursuits in all positions, so including even in that neutral position. That would be time to perhaps consider that referral. In terms of the referring on for a full vestibular physiotherapy assessment, probably things like if you're really noticing nystagmus or very markedly abnormal eye movement or true vertigo that's not responding to anything that you're able to do. For example, if you're doing positional things for BPPV. If they've got quite significant space and motion sensitivity that you feel is not related to the cervical spine, or visual motion sensitivity, if their dizziness is not resolving with the sorts of management that you're providing, BPPV that's not responding to repositioning, it may not be the most common one, which is the posterior one. It might be more an anterior, or it may be something else that the vestibular physios are much more familiar with. Any severe or unusual balance disturbances, and if you're doing things for the on that vestibular ocular motor screen, if you're doing some visual training related to that and it's not improving, and also if you really feel you're not confident to manage ocular motor and balance deficits, then it would be time to refer them on to a vestibular physio. So in terms of our integrated management then, in terms of people post-concussion, we would be, really good at looking at the neck and treating the neck, but we may also be required to take on the role of case management, where we are sort of referring on to people as required, providing advice and education about how about their symptoms and what could be driving those symptoms, and also being able to provide that prompt referral as required. And that could include, several of these things. It may be referring on to a neurologist if they have post-traumatic migraine, neuropsychologist for if they're having lots of problems with cognitive deficits, and psychologists perhaps if they're having significant problems with anxiety and mood disturbances. So in terms of the approach, we really want to monitor their symptoms, provide good advice and education, and also treat the systems involved. We would treat the cervical spine. We can potentially start some vestibular and visual things, as well as address that physiological system as well. In terms of the strategies that we would want to consider, so we're going to treat those systems involved. We also want to think about some symptom reduction strategies that we can give advice and education about. And then we also want to gradually challenge symptoms and try and habituate the system and train the brain as well. So some symptom reduction strategies, as well as doing things like treating the neck to help with their headache and help with their dizziness and those sorts of things. If they've got we really can help with things like limiting stimulating environments. So if it's lots of glare sensitivity that they're having problems with, you can advise about wearing sunglasses, having blinders so that that limits the sun, screen adjustments to their phone and to their computers so that it's more in a night mode, so it's not as glary, perhaps wearing a hat, that sort of thing. If it's auditory, they're quite auditory sensitive, then they can use apps that provide like a brown noise that can help with that. And then if they're having lots of problems with cognitive, then discussing with them what sorts of activities would be challenging and how they might be able to limit those with adequate rest periods, and the same with if it's a physical exertion, so how they might be able to adjust and modify that as well. So part of that is really educating them about the balance between rest and activity. So we really don't want people in a dark room doing nothing. Certainly we have to get that balance between rest and activity, and also, not telling people that they can't use their phone. If they haven't got light sensitivity and using their phone doesn't aggravate their symptoms, then it's fine to use their phone. It's really working out what symptoms are really their aggravating symptoms, and then trying to work out what is a rest for them and what's activity for them, and discussing planning and pacing of that, and perhaps defining restful activities for that patient. It might be important to advise on sleep disturbance. That's quite common in these patients, talking to patients about sleep hygiene and measures that they can take to try and improve their sleep. Nutrition and hydration is important, so that's something that we can advise on and perhaps point them in the direction if they need more help with nutrition. And then we also could be involved in return to work and return to school and sport accommodations. So, working out what things are there, things that are going to trigger their symptoms, how can you modify that, what strategies could you potentially use, and then how can you gradually challenge each of those things so that you're able to return them back to their workplace and school safely. In terms of challenging the symptoms and the systems, we really want to train the brain as well. So gradually we want to increase their tolerance to light and noise and a busy environment, for example. So it might be that while they're working on the computer, initially they start in silence, but then they might have some noise or radio in the background. They might work in a closed-in office, but then they start to work, where there's people around talking, so they've got that background noise. So you want to continue to challenge those things. It could be that they're exercising while they're listening to something, or exercising while they're watching something, so that you're really challenging all of those systems and gradually increasing the level of activity overall. So if it's challenging for them to walk into a supermarket, they may go, initially they might just walk in, get what they need, only a couple of things, and come out, but then gradually you want to try and increase how much and how long they can stay in those environments. Multi-system challenges, so things like dual tasking, getting them to perform an activity while they're doing a cognitive task, those sorts of things. And then challenges for return to work and return to school. What is it that they need to be able to get back to work, and how can you challenge that so that they'll be successful in that return? In terms of our management approach for neck pain, so certainly it will be similar to how you treat other people with neck pain, but you will need to integrate it with the other systems. And so that sensorimotor integration will be really important with visual and head movements as well. Thinking about the drivers, so if vision is a driver, then getting the visual system working as well. Do you need to be looking at the neck and getting it as good as it can be to compensate for any permanent vestibular problems? And perhaps you might have to treat the neck to enable other treatment. So if they've got a sore, stiff neck, they may not be able to perform their vestibular exercises, their fast, quick head movements, for example. So you may be able to enable other treatment to occur even if the neck is not that much of a problem in terms of causing some of those other symptoms like dizziness and visual disturbances. So certainly we want to be doing pain management, rehabilitate any physical impairments in the neck that we see, restoring their function and participation. So things like considering posture and ergonomic and work practices in relation to their neck will be important. Things like managing any movement and segmental joint dysfunction, so we can use manual therapy. We can also get the patient to be performing segmental exercises at home to maintain any gains that we've been able to achieve with our manual therapy and specific exercises. We also want to initially look at cervical neuromotor and sensorimotor control so that we're improving the capacity of those stabilizing muscles. We're training the coordination between the muscles and thinking about not only the neck but also the scapula, which can impact on neck pain as well. We would also be addressing those muscles so that we can improve proprioception and that feed-forward response. And we would be getting them to do any sort of sensorimotor control work with related to the neck. So, and that would be tailored to the patient. So if they can't do joint position error to the right, that's what they would practice. If they're having a lot of difficulty with the cervical movement sense, then that's what they would practice. So whatever that you've found as a deficit in your assessment, then that you would add that in as a exercise for them to improve their sensorimotor control. In terms of progression then, once you've got neuromotor and sensorimotor behaviours going quite well and addressing, then it's important that we move on to improving neck strength and endurance. We certainly, and we'll talk about in prevention, that neck strength has been shown to be a factor in prevention of concussion. So again, the level of strengthening and endurance that you would need to consider would depend on your patient and the patient's requirements, but it should include, you know, things like the scapula, strength and endurance, the neck flexors, the extensors, things like upper trapezius, etc. And in some patients, you may also be adding, you know, some significant weights and things to that to try and help improve their strength of their neck, so that they're able to return to their activity safely. We need to also think about management of other systems. So are there vestibular or visual exercises that you could give the patient that could help them with some of their symptoms? Do they need to be referred on to a psychologist or a neuropsychologist? We've talked about nutrition. In terms of the autonomic nervous system, if they have that, that's their main problem or one of their problems, then thinking about things that try and reduce sympathetic nervous system activity. So things like meditation, mindfulness, stress inoculation, so, you know, teaching them about body scanning, those sorts of things, relaxed deep breathing, and sleep hygiene as well. But exercise has been shown to be quite helpful in addressing this autonomic nervous system treatment of exercise intolerance. So from that Buffalo treadmill test, you can determine the heart rate, that was their tolerance where the symptoms increased more than 2 out of 10. And then you prescribe exercise at 80 to 90% of that heart rate that they reached before the symptoms increased. So that it's been shown that doing exercise 20 minutes a day at that heart rate has been beneficial at improving exercise intolerance and improving symptoms. In athletes, you can push them up to 90% of that heart rate, and you can push them to twice a day with split sessions. It is important often that they do have a heart rate monitor so that they can determine that they're reaching that heart rate and can stay there in that 20 minutes. And that's why aerobic type exercise is important. Things like weights and high interval training are not so good because they tend to spike their heart rate and reduce it all the time. You really want to try and get it to that stable heart rate and keep it there for that 20 minutes. They shouldn't really exercise if they're not feeling well or they've got really exacerbated symptoms, and they can increase their heart rate by about 5 to 10% each week. You don't need to reassess the treadmill test as long as things are going well. It is hard if they haven't got a heart rate tolerance of 110 to start with, because 110 is quite difficult to, not go above with exercise. So other things that we discuss, such as mindfulness, meditation, those sorts of things may be helpful if you've got someone who has extreme exercise intolerance. So in terms of what you do when people say, I'm fine now, I don't have any symptoms, thank you very much. This is where it can be quite important to make sure that we have challenged all the systems together. So things like looking at dual tasks, looking at reaction times, looking at physical exertion when they're doing quick head movements, when they have to put their neck in different positions, etc. So that you're really challenging all of the systems together to make sure that that will not bring on any symptoms. And then the other thing to consider is really their neck muscle function, stability and reaction, because that could potentially be something for prevention. So they would need all of these things to try and ensure that they can return to sport safely. We'll just quickly touch on the role of cervical spine in prevention. So there's been some work in this area. It still needs more to be done, but certainly there's a feeling that perhaps if we can decrease the transfer of energy from the head to the brain during these contacts, that perhaps the neck could be potentially involved with that. So that might be with activation, being able to quickly activate the neck muscles to reduce that energy transfer, to have a strong neck, particularly the ratios of neck strength, so the ratio of neck flexors to extensors, so that they're able to quickly generate and have the strength to transfer that energy, and also to be able to anticipate and react quickly that a collision may occur. So with that respect, it might be things like really looking at the strength and endurance of those neck muscles, that ratio. Segmental mobility might be important, because if they're quite stiff in one area of the body, say particularly in that upper thoracic, it means that the forces can't be translated as well, and perhaps the neck and head have to take more strain. Similarly, if they tend to be quite stiff in the neck and there's only one segment that tends to move more than others, then that might be something to consider as well. Perhaps head stability, so this one here, so looking at, when they are succumb to a force, are they able to keep their head stable and not wobble as much? And then perhaps some head reaction time. So how quickly can they get out of the way if they can see a collision coming? So there's more to be done with that prevention side of things. And there's certainly lots of research at the moment in that area. So we need to keep up to date with that, because there'll be more evidence coming as to, what is the best way to address this with respect to prevention. And I'd just like to acknowledge the contributors of the research and our collaborators as well. And if you're interested, that the book there is the book that we've done, which does have a lot of the assessment of the musculoskeletal as well as sensorimotor for the cervical spine as well. So if there are any questions, as Pierre said, certainly please let the IFOMPT know, or you could email me directly as well. Thanks very much for your time.
Thank you very much, Dr. Treleaven. I think that was amazing, and it really actually highlights the role of a physio in concussion. And I think in a lot of areas in the world, there's been a lot of reluctance, for us to take up our role in concussion, but there's been a lot of evidence coming forward, and you've certainly made a watertight case for our involvement, or how we should be involved in these patients. So I have two questions for you, if you are happy to answer those for me.
Yeah.
So the first thing I want to ask you, right in the beginning of your presentation, you mentioned the forces if you compare whiplash with a concussion. But I was wondering if you have seen smaller concussions have an accumulative effect, and if that presents similar to one single big concussion as such.
Yeah, so there is some work being done in that area, particularly in the NFL players. So they all have sort of sensors in their helmets and things. And so they think that perhaps it is just that repetitive, the number of times that they're having these contacts to the head might be an issue. But they, you know, in terms of actually causing a known concussion, that somebody says, oh, you've had a concussion, that might not be as noticeable, but they might start to develop symptoms over time. Something else I was going to say, it's popped out of my head. Was there two parts to that question?
No, you know, my thinking was more exactly like you said. There was that Hollywood movie called Concussion. That's the one. I think it was obviously made Hollywood specific with the drama, but that was quite a powerful message that as soon as it comes into professional sport and money is involved, that you know, a lot of these players would possibly hide symptoms, and you know,
yes.
if their livelihood is at stake, it impacts them reporting any symptoms, I suppose.
Yes, yeah, and that's where, you know, it's really important that we have lots of objective tests that we can use, because sometimes people don't report symptoms, and sometimes they actually don't have any symptoms, but they still have these deficits. So that's why it's important that we're able to, you know, assess across a lot of these different domains to work that out. The other thing I was going to mention was sometimes people who've had several concussions, particularly if they've had quite significant symptoms after one of those concussions, they often report that the next concussion didn't seem to take as much. So, you know, there wasn't as much force, and you may have seen that. You know, sometimes you've seen that, particularly in our, you know, our rugby league. You know, there are players where they have had a concussion, returned, and then they have another concussion, but it didn't look as, you know, obvious as the prior one. So there is some, you know, that they haven't really done the forces involved, but there's certainly anecdotal evidence of people who've had a concussion saying that the next time, that if it was in a short time frame, that it didn't take as much to cause the symptoms to reoccur.
Absolutely. My second question is based on something you mentioned, and I love the detail of all the assessments that we do, and it's really, as I mentioned, it makes a watertight case for our role. I was wondering if you've experienced any barriers in terms of how, for instance, a neurologist may see our role. And from a personal experience, as I said, concussion isn't a mainstream area of physiotherapy, and I suppose the argument can be that many specialists won't think of physio as the person to refer to. Have you noticed any specific barriers from specialists, such as neurologists or such, referring on to physio?
Yes, unfortunately. So, and unfortunately, they don't have a very good understanding, or some of them don't have a good understanding of concussion. So I've had patients who have had, you know, significant symptoms, significant glare sensitivity and visual disturbances, etc. And, you know, the neurologist has said they're fine, they can return to work because they can't find anything structural, for example. So a lot of these, as I said, a lot of these things, they can perform smooth pursuit eye movements, they can do saccadic eye movements. There's no obvious deficit with that, but it causes a lot of symptoms because they're trying so hard to be able to perform that activity. So some of those people, particularly if they're not working in that area, then they're not aware, and so they may not be referring. So some patients do take quite a while to present because they have just been searching. They're trying to search for people who understand their condition. So hopefully things are improving. In the last, I think it wasn't until the 2018 consensus statement, or 2017, that they actually recognised that concussion was a rehabilitative injury. So that's, you know, up until then, they really just thought people had to rest and wait for symptoms to go away. So I think, you know, now that it's been recognised that it's a rehabilitative injury, hopefully people will be a bit better at referring on. And I think we just have to be able to advocate and demonstrate we're in a perfect position to be able to understand a lot of the systems that are involved in these symptoms. We understand the neck, we understand visual, vestibular system, and we can certainly, you know, do the exercise intolerance testing as well. So as far as one professional that can potentially be across a lot of those areas, I think that's where we sit.
Absolutely, and you mentioned that us being the case manager and the point of call to say, you need this person, you need this person, integrating everything, and I think that was beautifully highlighted. So thank you so much for the work you've done in the area. It's highly appreciated, and I'm sure this area of physio is just going to improve with more people being inspired to go into more research about this. If anybody out there has any other questions, please email us, as I mentioned earlier, admin@ifompt.org. And Dr. Treleaven, I have a little gift on my side, which I will get to your side in due course. But thank you so much for giving this lecture and for your participation. For everybody else who's watched, we hope you've really enjoyed it. Your certificates will be sent to you via email. Please give us some feedback on the session and what you liked and what you didn't like. And if you have any ideas or suggestions about future topics, please let us know as well. We'd be happy to hear about those. We have many IFOMPT webinars that we're planning for the rest of the year. So keep an eye on your inbox and the IFOMPT website, of course, and our social media pages, and we'll be announcing some exciting webinars to come. Thank you for watching.
Thank you.